All right. So I guess we'll do introductions so that Christine can hear who we are and kind of what our role is and where we're based out of. So I'll start. Peter Rumbach with the Evaluation Center at CU Denver, and we do evaluation technical assistance for the Partnerships for Success grant, which is focused on reducing youth substance use for alcohol, marijuana, and prescription drugs. And there are 5 communities along the Front Range that receive funding through that grant.
All right.
Then you want to go?
Okay, I'm Lynn Chang. I'm from Pueblo, working for Crossroad, and I'm also on the grant on SPF, Substance Prevention Framework, and I'm also the evaluator. I was trained as a statistician.
Nice to meet you.
Nice meeting you.
I am Will Patterson. I provide evaluation support, internal evaluation support for the Aurora Mental Health Center, but it's a small staff, so do some program stuff as well.
Very cool. Nice to meet you.
Christine, would you like me to introduce you, or do you want to introduce yourself?
I can introduce myself.
Okay.
So my name is Christine Williams. I currently manage the Smart Source project, which I'm going to share a little bit with you guys today about. And I'm currently at the Colorado Education Initiative, but will actually be leaving in like 2 weeks here. So I'll talk a little bit about the transition of Smart Source, but my future organization kind of remains to be seen, but I'm with CEI right now. So I am going to share my screen so you guys can look at the same slides as me. All right. Is it the presenter mode or is it the right one?
Yeah, it looks like presenter.
Okay.
Right now.
I have 2 monitors and I'm not sure which one. Okay, what about this one?
Yeah, presentation.
Okay, great. So this is our Smart Source logo. Will, and was it she? I didn't catch your name. My internet had backed up, but I'm seeing your user. Yes.
Chang.
Chang.
It's like Smith in the world. Chang.
I see. Okay, great. Well, I don't know have either of you guys heard of Smart Source or have any context coming into this? It's a survey in schools.
It kind of rung a bell, and I poked around the website a little bit, but not much. It's not a data source that we tend to use or have used.
No, well, that's good to know. So I was just going to provide some background, talk about our most recent administration, and then really introduce you guys to the data and how you might be able to integrate it into your current kind of community data use set. So the main purpose of Smart Source is to serve as an inventory of school health best practices, practices and policies. And it is kind of a multi-tiered purpose. When it was first developed, really prioritized reducing burden on schools by streamlining the numerous duplicative school health surveys that were out there, really in order to improve the quality of school health data that we are getting, and to ultimately just have a quality data set that Colorado can use to guide allocation of resources, both from the state and also federally. So this all kicked off in 2013. That's when the initial development of the document began. And so it aligns with the logo to your left.
Hey, Christine, sorry to interrupt you.
Yeah.
On my end, the audio is kind of going in and out.
Okay.
Me too.
Let's
Okay.
I'm going to put on this headset and see if that helps. Give me 1 second. I'm going to actually disconnect from my other monitor.
Oh, that already sounds better, I think.
1 second. need to speak to mic in. Hold on. Let's try. Can you guys hear me?
Yes.
It doesn't sound
Yeah.
clear. Do you think? Well, it's not coming through the headset though. Hold on. Headset. Okay, what about now?
Yes.
I
Okay,
think that sounds better. Yeah,
okay, great. Sorry, thanks for bearing with me with that.
that's okay.
Okay, can you guys all still see the slide?
Yes.
Yep, okay. So these are the 10 components in SmartSource. So it spans physical and social emotional indicators in student health, and then also has the 9th component area for staff health. And then this last one that we added, probably not as relevant to you all, but for schools that participate in the USDA meal program, we need to assess their local wellness policy. And so we added this to the survey just to support schools in that way. But the 1 through 9 components really align with the WISC model. Some of the items, so there's lots of items in SmartSource, I think around 180, but I just wanted to give you guys some examples. And I know Peter shared the website with you all, and the full instrument is available there as well. But I thought I'd pull out these 3 as they seem to maybe be more relevant to substance abuse prevention and school mental health. So a lot of our items are matrix items where there's a general STEM and then lots of sub items. So this first one is around health education staffing. There's also lots of items around the content of health education. Moving down to the bottom left is one of, I think there's about 10 items in our counseling section. And we align this section to an MTSS model, so with tier 1, 2, and 3. And these are just some of the items that we ask specifically about tier 3 students or students who have been identified for tier 3 interventions. And then over to the right, an item that we use very often actually, since student engagement in school health is really something that we want to be seeing across several different component areas. The more student involvement you have, the more relevant the practices will be and the interventions will take better. So this was just a really quick snapshot, but I would encourage you guys to view the entirety of the tool. And going back real quick, I imagine that the health education, number 4, counseling, psychological, and social services, number 6, and then 7 and 8, the healthy environment and family, community, and student involvement would be most relevant for your evaluation purposes. So just a sense for the process that we do. So SmartSource is administered every odd number school year. So we just closed our administration for the 2017-18 year. Our next full administration will occur in 2019-20. This schedule will be adhered to much more strictly moving forward. Before 2017-18, we did allow the instrument to be passively accessed by schools and districts if they wish to self-assess, and it kind of remains unclear if that's going to continue, for example, for this upcoming school year, 18-19. But the schedule, so we open in September. We have a point of contact that we refer to as the site coordinator, as the person who reaches out, and we then send the link. So the survey is administered online through Qualtrics. We then encourage that site coordinator to really convene a team to complete the tool with representation from lots of different staff members, including administrators, PE teachers, food service staff members, health educators, et cetera. So they can really speak to the comprehensiveness of the indicators we have. We then close in mid-January, so we can turn around and give reports, and I'll show you what those look like, but we return data in 2 waves. The first is with our immediate report, and that goes back to schools within 1 week of submission and doesn't have any aggregate data. It's just the school's response as compared to best practice. And then our final reports, which do have comparison data, we return those in February. And then we also conduct trainings throughout the spring, geared towards school and district staff, but we've definitely had some community members join in those too to really learn about interpreting the data and putting it to use, and we, which I'll show in a little bit, walk through a data inquiry protocol. So any questions on like the schedule of our administration?
Just to clarify,
Yeah.
is this for staff to answer, to respond?
Yes, so it's one survey per school, and the ideal methodology is for a team of staff members to be completing it. Sometimes in schools where they're just really beyond capacity, we do have like a site coordinator or principal completing it, mostly in its entirety, but the best method would be for a team of staff.
Thank you.
Mm-hmm. So this is a snapshot of participation from our most recent administration. The grand total number was 677 schools, which represents 37% of all schools in Colorado, and we were really excited. This was definitely our biggest administration to date. And in the state of Colorado, this is the biggest or the highest participation in any school health survey. So we hope to only see numbers like this and for further growth as SmartSource continues to become a statewide data system. I don't know if it's of interest, but it also, we show splits by school level. So we have elementary, secondary schools, and then combined, which is what we refer to as schools who have both elementary and secondary grades. And then also distribution by region. And this particular category of region is assigned by the Department of Education, or CDE. We will be pursuing slices by health statistics regions as well. Those just aren't as common to schools and districts, but definitely as we try and integrate this in public health data use, wanting health statistics regions to be available.
Can you, do you have the capability to pull out specific districts?
Yes, certainly. So I'm going to get to that kind of at the end, but around how you guys can access specific school and district data. But in terms of like publicly available participation tables, we haven't split it out by districts just because there'd be like 100, and I think we had 115 districts participate.
So Christine, quick other question. Based on your sample of schools here, how representative is it of overall by region, the total number of possible schools that could have participated? I guess by elementary, by secondary, is it representative?
I probably should have pulled in some other tables, but we didn't adhere to a sampling frame. There just wasn't capacity at CEI to do that this year. There are plans for 1920 as SmartSource transitions over to CDPHE to use sampling. Definitely at the secondary level, but it remains unclear if it will happen at the elementary level. But in terms of just opt-in, which is what all of these schools were, just opt-in completions, the percentage of schools by school level is, we say reflective, because I don't want to say representative since it wasn't a sample, but by far we have the highest number of schools in Colorado is elementary, then secondary, and then combined. So it follows that pattern. And then similar with our regional distribution, we have the highest participation in the metro region, which is most densely populated or has the most highest number of schools, and then Pikes Peak. So these are just rough non-statistical comparisons because we don't have weighted data at this point in time. But in terms of high level comparisons, it is tracking with those patterns of distribution.
Thanks.
All right. So SmartSource is a school level tool. So we start with school level data. That's what goes back to schools. But we also aggregate at 3 higher levels. So first with the district, and we do return a district level report to district staff if they are interested. And this will aggregate all of their schools' responses and just show a district aggregate as compared to the regional aggregate and the state aggregate. So that's the comparison data is at the regional and state level. And then additionally, we have publicly available data that's aggregated at the regional level. And then also, I'm going to just flip a screen. is stratified by district size under the spreadsheet category. Free and reduced price lunch categories, so those are quartiles, region as defined by CDE, and then health statistics region. And these are just about to be posted. We're just getting finalization by our graphic designer, but they should be posted within the next week. And then we're also having fun making some data snapshot one-pagers where we're just pulling out items of interest that fall within themes of district size, systems and culture, and equity. So I imagine the spreadsheets will be more useful for you all if you're interested in high-level aggregate data. But it also sounds like there may be interest to see specific school and district data. So we will get to that right here. So this is what I just took some screenshots of our immediate report, which is the one that goes back right after schools submit. And we present on the cover page a summary of results figure that shows at a very high level the percentage of responses that align with best practice. That's the consistent metric in our reports, is whether or not schools are aligning with best practice in their current health efforts. And you can see kind of the distribution of strengths or areas of improvement across the component areas. But then the actual report, the meat of the report, is by component area, showing for each item, and it does match item for item for the tool, what the school's response was, and then how that aligns with best practice, using a check mark to indicate you align with best practice, and an X to indicate that you do not align with best practice. And then lots of footnotes to provide additional qualifications about what the best practice is, or if there's just more of a nuance to the best practice and we wanted more information. So that is one report type. Real quick, I don't want to spend too much time on these because I'm not sure if it's as relevant to you all, but our second report type that we give to schools is a final report, and this now layers in the comparison data. So the state aggregate in the blue bar and the regional aggregate in the gold bar. And for yes, no items, in order to layer the school's response, we have to do the check mark or the X. So for example, looking at the first indicator, whether the school requires predominantly healthy foods and beverages for celebrations, this is a nutrition item. We can see the percentage of schools in the state and the percentage of schools in the region. And then we also see that the school reported best practice, which is why there's a check mark. On the right-hand side is another way that we visualize data, and it depends on the item type, but if it's a numeric entry where the response is an actual value, we can then show the averages for the state, region, and school, all using a bar chart. And this one specifically is PE time, or the percentage of PE time with moderate to vigorous physical activity. So that is, this is what comprises the final report. It's about 25 pages of various figures and tables. I will say the immediate report has more items. Like I said, it's a match to match item per item of the tool, whereas the final report, for the sake of having it be a digestible document, it's a selection of some of the more relevant items. So it just depends on what schools are looking for. If they want to see some comparison data, they can look at the final report here. And then also we provide a spreadsheet that has all items and all best practice responses compared to the school's response, and then the various aggregates. This particular screenshot, there's a lot of dashes, but hopefully they tend to be more filled in. We also show trend data. If a school participated sequentially in more than one administration, those are layered next to each other. And the dashes happen for suppression criteria. So if we have less than 5 schools respond to a given item, and there's a dash. Any questions on the, I know I kind of went kind of quick, but on the various school reports?
I'm curious, so was 15, 16 the first year? I'm sorry if I missed that.
No, I didn't say that. So technically 14, 15 was our first pilot. There were only 77 schools that participated. We don't report broadly, though, those aggregates just because it was such a low power sample and it was really a testing piloting year. So 15, 16 was the first like official administration that we share aggregates. And we don't for 16, 17, even though there was participation in that year, but it was what we call a passive administration, and we didn't recruit heavily. So we had, there was 130 schools, so it was much smaller. So we stick to the odd year school years.
So if you were looking at one school and they happened to participate 15, 16, 16, 17, 17, 18, they would be able to see across 3 years their,
Yes.
their trajectory.
In the spreadsheet, that's the only report that they would have that trend data, so they could see if their responses change over time.
So you wouldn't be able to give us data by school, right? That's because that's a sample of
Yeah,
them.
so let me actually just flip forward. So school and district data, just by our data sharing protocol, it only goes to staff of those entities.
Okay.
And they can choose, so if you guys have relationships with people in your schools and districts, they can totally share it with you directly. We are also happy to serve as a connector and can put you in touch with district and or school staff that we know are familiar with SmartSource, and just say like, hey, you know, this person from Partnerships for Success, this is what they're interested in and how you guys can partner. So we can serve kind of as that liaison, because we definitely want community access to SmartSource data, but just have this barrier. We can share though with you a list of participants. That is something that has been determined to not be sensitive by any means. So if you just want to see, and I do have a spreadsheet that's distilled down to the counties you work in, there's 5 of them, to see across all years if any schools have participated in SmartSource, and if you would like to get a hold of that data.
Okay.
Some other options. So we have a report type that basically creates a custom aggregate. So if you said, based on schools that participated in SmartSource, you wanted to aggregate all the schools in Larimer County, we could do that as long as there's more than 5, and you would see the collective, refer to it as the collective aggregate throughout the report as compared to the regional and state. And those aggregates are publicly available. And then the last resort, and I won't say last resort, it just sounds like from talking with Peter, this isn't necessarily the way to go, would be to create a data sharing agreement with CEI, where we could then release fully raw school and district data. But if you were to publish or be in a meeting, you wouldn't be able to identify the data. It would have to be de-identified, so it wouldn't be as useful in a community use setting. So I feel like the best way is for you guys to get access to the actual school and district data through those entities and partner with them in using it and incorporating it into your evaluation.
Great.
That sounds good? Yeah.
How many data points do you usually get from each school?
A lot. So there's 180 items. And then, so for each given year, there's going to be 180 responses. And then those are compared to the 3 aggregates, state, regional, and district. So that would be.
What I meant is how many respondents, how many subjects?
Oh, yep. So we had 677 schools in our most recent administration.
For each school.
Oh, it's 1 survey per school.
So 1 survey per school.
Yes. So the way that.
Don't report school data, you just talk about. Well, because that will be individual point.
Right. So unlike like a student level survey, like Healthy Kids Colorado survey, where they're looking at individual data, SmartSource is a building level tool. So it's an inventory at the building level. And so there's really just 1 survey per school that it's assessing practices and policies. So it wouldn't make sense to be doing it multiple times, because you just want one response for the school. Right. Hopefully that's informed by multiple staff members.
Right.
Yeah, one survey per school.
Okay.
Real quick, Christine, just reading that collective report. So it sounds like for bigger counties where if you had certain 5 or more schools that you've worked with, say just at the secondary level or just at the middle school level, you could potentially publicly get those from you all if they're aggregated. Is that right?
Yeah, I wouldn't say publicly, but we can share them with you guys if it's of interest. Mm-hmm. Because you're a community partner, and that was kind of the intent in which the collective report was designed. And it's still confidential, or the individual schools are kept anonymous because of the aggregation.
Okay.
So if that's of interest, we can definitely pursue that too. So one thing I did want to touch on, so I know you guys use Healthy Kids data, at least that's what Peter had shared with me. And so just wanted to walk through an example. This is actually pulled from our data use trainings of how we relate indicators from Healthy Kids to SmartSource, because there is a lot of overlap, and I'll share with you guys a crosswalk that we have by section. But in Healthy Kids, they have a few indicators on suicide ideation and just mental health in general. This one is specifically looking at, sorry, question for you guys. Do you see this square in the middle of the slide? Please move.
Yes.
Oh, no.
That's okay. It's been going in and out, so I didn't want to interrupt you again.
So annoying. Okay, now it's going out. Oh man, I just thought that
it
was
goes in and out.
I thought, okay, that's bizarre. How can I
remove that window away from me?
I know it's saying please move, but it doesn't let me click on it.
That's a new one for Zoom for me. I've never seen that.
I'm going to stop my share and then start it again and see if it clears. Okay. I wonder if it was because I had the two monitors and then I unplugged the one, if it.
Oh, so it's gone now.
I'm so sorry if that was blocking.
That's okay.
But anyway, so this is a sample school report. So I'm not sure the level in which you guys engage with Healthy Kids, but this is what goes back to schools. They do frequency tables. And this particular one is looking at the percentage of students plan about how they would attempt suicide during the past month. And so the totals, I mean, these are all sample, but they actually, I've heard from their staff, they do reflect the state overall. And so we would encourage schools to be looking at the frequency of students who are planning suicide and then compare it to their school practices as noted in SmartSource. So this particular item is looking at access to a school counselor. We see the school's response shown with the X over 0 hours per week, and this is sample data. But that would indicate to the school, you don't have a school counselor. That is not best practice, hence why there's an X. And you can see the comparison data for reference, the highest proportion of schools having 30 to 40-hour access to a school counselor, but that would be a protective factor against suicide ideation, having qualified mental health practitioners in the school for students to access. In addition to, I'm highlighting with the arrow, universal screening. So that would be a preventative intervention to get a sense for indicators in mental health, such as feeling sad for 2 or more weeks, and just having a universal sense for what's happening in your student body to pick up on some of those early indicators before more severe behaviors. So that's kind of the layering that we suggest, having your student level data, finding trends, seeing what your population needs are, and then comparing it to what practices and policies you have in place and where you can identify strengths, but also areas of improvement to then create action plans around and hopefully develop interventions. So those are kind of the 2 levels of data that we really are encouraging. I'm going to skip forward. So I'll wrap up here. I know I skipped some slides, but they were kind of just cushions anyway. So SmartSource is transitioning, and I mentioned it a little bit before, to the Colorado Department of Public Health and Environment in advance of fall 2018. So Kaiser Permanente funded CEI to be the owner beginning in 2013, really to develop, incubate, and scale SmartSource, like I said, from the first pilot of 77, now all the way to a full-scale administration of 677 schools, and hopefully only more to come. And it's really now being seen as a statewide data collection effort in the realm of school health. And so having it housed at CDPHE only offers more opportunity for coordination with Healthy Kids, And there's lots of overlap and really interesting analyses that can be done with that study or with that survey. And then also just from a logistical standpoint, CEI is a small nonprofit in education. And so it was really growing beyond what CEI could manage. So now being at a state agency, we'll be better suited there. So what questions do you guys have? That's all. I know that was a little bit longer than I think I planned on, but
we interrupted you throughout.
Oh, that's okay. No, that's the way it should go. I think I'll go back to the slide.
Ben or Will, did you guys have questions?
Do you think that you could go over kind of the main domains and subdomains? Like, I think the most useful part of it for us would be able to look at whether our district is adhering to best practices and where the gaps exist.
Mm-hmm.
So it looked like there was a sheet that would kind of display that at a higher level.
Like the components of the actual tool? Is that what you were?
Yeah, not the individual items, but it seemed like there was kind of more broad groupings of them.
Yes. Okay. So in the instrument itself, the only categorization that we show is the component headers, and those are listed here in the table of contents. And as you're scrolling through, you see those split out. But where there's kind of subgroupings, actually we do those in the reports. So let me go back here. So this is our website, which I know Peter shared. The more info tab, you can get the actual inventory. And
Sorry. I can't actually see. I can only see the PowerPoint right now.
Okay.
Yeah, I was gonna say I can share the website too.
Okay. Yes. Can you see? Let's see. I'm gonna stop share. And then, oh, you know why? Because I select what screen to share. It doesn't move with me. Okay. What about now?
Yep.
Okay. So I was just showing you the instrument, but it sounds like what you were more interested in is something that we do in our immediate report, where for each component area, we do provide kind of subgroupings of items just for this. We did it honestly for, I think, report interpretation for people for the items to be broken up. But let me go down to, because your area is in substance abuse prevention. So I imagine health education would have the most items of relevance. So this is just looking at grades offering health education, the average health education minutes, and all of the footnotes indicated over here, 23 and 24, those are going to give the specific best practice recommendations in numbers. But just to kind of scroll through here, we have the staff that are teaching health education, the training for staff, requirements. Scroll down here. So we do have alcohol, tobacco, and other drug use prevention. We ask whether that's a topic included in health education. That's probably the most specific. And then just general best practices around inclusivity, sexual health, and health education integration. I would also think you guys would be interested in the counseling section, counseling, psychological, and social services, as kind of higher umbrella of, or just assessing the school mental health system. So looking at staff access, scroll back up, staff access, training of staff around supporting students with social, emotional, and behavioral health needs. Mindfulness was a new indicator that got added based on research. So that's been really promoted as a evidence-based practice now. And then splitting into the MTSS indicators. So are you guys familiar with the Colorado School Behavioral Health Services framework? Do you guys, I don't know how much reach there is. It seems to be pretty well known around like school mental health staff, but this was developed in partnership between CEI, CDE, and CDPHE. But it basically translates the multi-tiered systems of support into like an actionable framework for what schools can be doing at those various tiers. And so that's how these specific indicators were classified, is based on that framework. So I could share that with you in a follow-up email just if you have interest.
Yeah, that'd be good. We like to post the resources from each roundtable, so I could put like your PowerPoint presentation and that document as well as some others.
Yeah, let me see. It's not going to be linked in the report, but I go here, just show you what it looks like real quick. So it's like a report brief, and it kind of gives context to school mental health systems, why the framework was developed. And then, excuse me, as I scroll real quick, I'm just going to get to kind of the overall framework, but it puts it in a very digestible image that says, okay, for tier 1, for all your students, what are things that you should be doing? What are best practices? And then as the tiers narrow, rolling up, and then there's specific narratives breaking down all of those sections. So I think it's a really great resource, kind of the first of its kind in terms of something that's written for educators and school mental health professionals, kind of bridging that research to practice gap. So anyway, I'm kind of rambling at this point, but I'll be sure to send this to you guys and the like some sample reports and my PowerPoint so that you can share this with the rest of your coalition. But
yeah,
oh, go ahead.
To Will's point as well, I found, so I don't know, Will, if you looked at the actual data tab and then it had the 15, 16 by state and then by region, but you can download and look at the items that were asked on the survey on the left-hand side, and then it's bucketed by the big domains. Mm-hmm. That was helpful to know, like, okay, this domain seems useful, and then looking at specific items, just another way to look at it to mirror that report I think you guys put together.
Yep. And I can, let me see if I can get my screen share to work again. So these are outdated. They will be updated, like I said, within the week of 17-18 data. But this is what Peter was describing with the items listed by the component areas. And they are like to the letter. So they match what the actual school has to get a sense for what's assessed.
Yeah. So, I mean, I guess that's a good question. In making a data request, do you ask that people, well, I guess, how do you normally request that people make those? And then 2, can we select specific items, say that Will is interested in, X number of schools, but only interested in these 35 items? Is that something he'd be able to do, or do you generally provide the entire spreadsheet like this?
Yeah, we've done both types. So we had to report some data to the CDC when we were trying to integrate their school health profiles indicators. And so they just wanted the select indicators that they were interested in. But we definitely, I would say more often just do full data sets for people to dig into, but it's really easy to narrow in if that would be of interest. But again, that the raw data sharing could only happen with like an agreement in place. Otherwise, the actual school and district data can be shared through the appropriate staff.
Christine?
Yes.
You reported data on you talk about school level, district level, regional level, and state level. I was just wondering, do you do county? Like, for example, our county has a couple of districts, and we will be interested in knowing what we do in comparison to the state level, rather than just regional. Because if we're hoping to find out what we do here, do you respond to requests like that?
We haven't done county. That could be, though, accommodated through the collective report. I will say, so the health statistics regions, they, in some counties, like a single county will be its own health statistics region. I don't know if that is the case for your specific counties. I can look into that, but we do report out, and we don't have it posted yet, but it's coming for 17-18 data disaggregated by the health statistics regions. There's the 21 of them. So that might be something that could also work if you're just wanting to see your individual county.
Okay, another one, just a comment. I think I find this, even though it's overall it's self-report, it's rough, but I find it useful. For example, in one of your PowerPoint, you were showing by categories, and I noticed that even at the state level, the counseling mental health was very low. Not the lowest, but it's very low, like maybe just a third of the schools are doing things like that. So that's something that probably call attention, because I think more and more greater needs are showing from our teens and youngsters, that kids need a lot of mental health and counseling support.
Yes.
So more and more are depressed and doing crazy things.
Yeah, we have one of the highest suicide rates as a state in the country, and it's really emerged. I mean, anecdotally for me, in all of the trainings this year, unlike previous ones, school mental health was something that teachers and other educators just wanted to learn more about, because they're seeing it as a need and as something that's within their purview to provide to the young people they serve. So totally agree. And prior to SmartSource, there really wasn't a sense for how many schools are doing these best practices. It was just, you would maybe know in your district. But what's also been illuminating for me is for individual school staff members to be enlightened about things that their school is doing that they didn't actually know, or that they didn't know their school should be doing. So it's also like an educational resource in some ways too.
Real quick, Christine, can you identify, when a school sees a gap between a best practice and where their school is? What are some of the common reasons that schools might have for not achieving that best practice, or how have you seen individuals use these data to then pursue a practice or policy?
Yeah, I would say the largest or the most common response we get for why best practice isn't in place is resources, lack of resources, and lack of ability to implement. So this year, Colorado qualified for the School Health Professionals Grant, which I'm not going to remember the total, but it was a big chunk of money, and a lot of it was awarded to metro districts. But I was part of the reviewers of the applications, or I was a reviewer of applications, and to just see how understaffed our schools are, especially in school mental health, but even like school nurses, the ratios are off the charts as compared to where they should be. So, I mean, not to provide too much of a social commentary, but I think it gets back to insufficient funding in public education. So from a systems perspective, and then also there's a paradigm difference. I think certain administrators would say that the health of their students is not in their purview, that they are there to educate and strictly speak to academics. I think we're shifting away from that, and I'm encouraged by what I'm seeing in terms of district approaches and district strategic priorities that include the whole child, or just speak to health, school health in general. So that's been something. If we have a teacher who comes to us who's like, I'm really interested in school health and I want to get these programs off the ground, but I don't have a supportive administration, that's a really big barrier. So those are the most common. And then in terms of how schools use their data to identify gaps, it's pretty evident just by the checkmark and X convention that we use, where they're not meeting best practice. A lot of time goes into prioritizing and kind of triaging. Okay, what gap do we need to focus on? You definitely can't tackle them all at once. But I think one thing we were really emphasizing in our trainings this year is finding an area of improvement that aligns with district or school strategic priorities. So in your Unified Improvement Plan, which is a document that all schools have to create each clear that says what their goals are and how they're going to achieve those goals. If they have something written in that you can align with a certain health practice, then that's going to be that will gain a lot more traction. One that, and because when we had spoken, you said to share some examples. I wish we got more feedback about how certain things are being implemented because of SmartSource. I don't say we actually get to hear a lot of it, but we did have a school email us saying that they were able to implement a restorative justice training for their staff members based on the gaps that they identified in SmartSource. And those are the types of things that we would encourage. There's definitely a hierarchy of interventions in terms of whether they're really at the systems level and going to have a lot of impact, or if it will be more surface, like having a health fair that might not have as much impact. Definitely feasible, but in terms of overall reach. So doing things like trainings or bringing on new staff, using data, gaining administrator support, those are things that are going to shape your system of school health and that we encourage schools to move towards.
Great, that's good. I think that's good advice on the unified plan for each school.
Yeah.
Really important. Yeah, if they're already pursuing a priority, that if you can align that some way.
Yeah. So something else I'll share with you guys, just because we're in the business of sharing lots of resources. In our training, we developed like a data inquiry protocol, and it kind of walked them through questions to interpret their SmartSource data, any other data they may have brought, such as healthy kids. And then the last sections are all around making connections to strategic priorities. So it really fleshes out how to identify areas of improvement that align with whether it's your mission and vision statement, your UIP, your district strategic priorities. So if you guys are ever able to connect with community members or school and district staff and work through this data set, I think it's the launching point.
Yeah. Well, what would our next steps be then if, you know, one of the evaluators was interested in making, I think that our data request might not be uniform across all of the counties. And so it might be individuals approaching you or however that would work. What would their next steps be?
Yeah, so I think the first step, and I'm going to pause sharing my screen so I can just open it. I have too many windows open. It's not, there it is. Okay, can you guys see the spreadsheet? So I'm going to email this to you. This is by all of the counties that Peter had shared with me. So we have Arapahoe, Denver. Oh, Dolores wasn't one of them. That should say Douglas. I need to correct that. Douglas, Larimer, and Pueblo. I'll correct this and send it out. But you can see which schools participated, the district that they're in, their county, their health statistics region. I should probably not abbreviate that so it's more clear. But this would be step one, is to just see what's even available, what schools have participated. And then from there, deciding really, I guess, the ways in which you hope to engage with the data. Are you wanting to do it in partnership with school and district staff? If so, I would inventory if you have any connections or relationships at these schools. If not, we can help. Let us know which schools or districts you're hoping to get in touch with, and we can do some email intros. And then I would say, just based on what is your intended outcome, decide your steps from there.
So, I mean, I can say right now, because that's all of APS, or not all of it, but a lot of schools.
It is, and this is for multiple years too, so.
Okay. Mm-hmm. I think that what would be most useful for us would be to get just the kind of like the general report that you guys have available on the website, but broken down for APS for elementary and secondary, if that's possible.
Yeah,
and
so that would be that's part of the district report that goes to a district staff member, but I could connect you. They actually, so a lot of your districts, you guys kind of looked out, have very involved district wellness coordinators. So DPS, Pooter, Thompson, Pueblo, the Pueblo 60 and 70. There's 1 or 2 staff members who are just dedicated to their district's school health. And they have a lot of these reports. So I can email that person and just share a little bit about what you guys are doing, and then that you would be interested in having access to their district data. And
Sure.
so
I was actually looking through my old notes as we were talking. I have talked to the district about this, and they told me to reach out to you guys.
Oh, interesting. Do you know if perchance you reached out to, was it Sarah Coleman?
No, but they told me to reach out to Sarah Coleman.
Okay. So I'm pretty close with Sarah. I feel like we've worked together for a while now, but I think she would, especially if she knew that you guys, the work that you're doing is just supporting their communities. I don't think she would think twice about it. I'm not going to like try and coerce her, but I can't imagine that they wouldn't want you guys accessing it.
Sure. So I should talk to Sarah about it.
You can, or I'd be happy to like facilitate that email conversation and just say that I did a training with you all, and given your work with Aurora Mental Health Center, that we would love to see the APS district data for SmartSource.
Yeah, that would be great.
Sorry, what?
You do that for Pueblo?
For Pueblo? Mm-hmm. Yeah, so they just got 2 new district wellness coordinators this past year through Health Foundation funding. And they're great. They're really involved. So I can set that up.
Thank you. That would be good.
Well, I think, oh, sorry, go ahead, Christine.
I was just going to say, as you guys kind of chew over this, and if you have other members in your coalition who would want connections, like feel free to email me. I'd be more than happy to start doing that.
Great, thank you.
Yeah, I think in a follow-up email, I'll just send it to the whole roundtable and kind of, give them next steps that they could reach out to you if they're interested in school or district level data, if they don't already have a relationship that they feel comfortable following through on. Does that sound good?
Yes.
Because I imagine building these relationships is only going to be better for both sides. So I would hope that they'd want to do that.
Do you know if the wellness coordinators, if building a relationship with them would have any impact on HKCS data and accessing that at a district or school level?
I would think so. I am not sure if individual school data is shared with district staff. We do for SmartSource mainly because it's not a sensitive data set, but I'm not confident. I can get more information on that. But it wouldn't hurt, because then that district wellness coordinator can connect you with a lot of schools have wellness teams, and they have designated co-leads or team leads that sort of are the points of contacts for the district people. So they can just kind of push things along and encourage it. And I imagine that a lot of district wellness coordinators have their school level Healthy Kids data just because the school staff shared it with them. And it went that way.
Okay.
So I think that would certainly help. And yeah, I can imagine Healthy Kids is a very valuable data set for you all.
Great. Well, yeah, go ahead. Sorry.
Lynn, have you guys gotten your Healthy Kids data?
No.
We were able to get it from APS.
From APS?
Yeah, so I know that it's been available to us.
The reports have all been sent out for Healthy Kids.
So
that's a good sign, Will. If they were willing to share their Healthy Kids data, they should definitely be willing to share stuff.
Yeah, congrats to you all.
Thank you. That felt like a big win.
Yeah. And for all, do you know what participation looked like if they had a good chunk of schools participate?
It was a lot more than in recent years. I think it was 900 or something like that district-wide.
Good. I think people are really buying into it. And
yeah, 2 years ago it was like 200 or something. So
yeah. Our metro districts, well, they're actually easier than some of the mountain rural ones, but I know they're just really jazzing up recruitment efforts because so.
Can't say it as far as last name.
Great.
Yeah. All right.
Great.
Well, if you guys have other questions, we'll be in touch via email. I'll send a follow-up email with the resources I mentioned. But thank you so much for this opportunity to get the word out about SmartSource and for you guys doing the work that you do. It's good stuff.
Thank you for sharing.
Yes.
Yeah, thanks for sharing.
Yeah, big thank you, Christine. Thanks for coming on.
Yeah, no problem. So I'm going to sign off. I'm sorry I took almost all of your call.
Well, that's all good.
Let's see. Stop share. And then I just exit out. I can control V. Okay. All right. Bye, everybody.
Bye, thank you.
Okay, take care.
See you guys.
So do you guys have to hop off right away? Because I know we're at time.
I have a couple of minutes, but not too long.
Okay. How about you, Lynn?
I'm all right, yeah.
Okay. Well, maybe just real quick, Lynn, we can touch on the data request that we put together and see if Will has any thoughts on it, if it would make sense to do a request on behalf of all the counties or just for Pueblo. It's an extensive list of variables and crosstabs that you're able to look at. Let me share it real quick. And so, Will, just so you know, this is something that Lynn has been thinking about and put together recently, knowing that 2017 data was coming out. So demographic variables she's interested in.
So hold on, Peter.
Okay.
Does it show up on your screen? Because I just have a gray box that says you've started sharing your screen, but
Okay, sorry.
there's nothing shared.
Right. Same thing, Lynn, you can't see my screen.
I can.
Okay. Well, I thought I had fixed that because I was using a different browser with Flash updated, but did it work there or still gray?
No.
Still gray.
Well, that's okay. Let me just pull it up and I'll kind of describe it to you, Will. And I know we can share it, but basically it has different demographic and grouping variables, which grouping would be by county, school district, and school. And then the bully, violence items, mental health items, safety items, items around tobacco, alcohol, marijuana, and other drugs. And then some crosstabs where Lynn was interested in looking at bullying or violence by substance use, mental health items by substance use. And then it's a pretty long list of crosstabs that she's interested in as well. So I was just wondering, you know, at a school district and county level, you'd make a request through HKCS, I'm pretty certain. As far as getting crosstabs through a district and school level, I'd have to follow up on how that would happen. Bill, when you got APS data, you got access to de-identified raw data or you got access to summary data?
So, sorry, what was, you kind of broke up there. What data source?
So for HKCS, when you got data from APS at the school and district level?
Yeah, it was just aggregated data. So we have it at the district level and we have it for one school that we're working with at the school level, but it's just aggregated there as well. So it's not.
Peter, let me interrupt. I think at this point, if we can do state and county level data, will be fine. Not all the grouping that I listed there, you know, because there's no reason to believe that the relationship vary among schools. Do that make sense? For example, the one protective factor that is actually shows stronger for one school and less for the other school. Because I would hope, you know, a protective factor is a protective factor that will be working the same for all kids. So right now, I think state level and county level. I mean, county will be good.
And that's a data request through HKCS,
Yeah.
which we already have done for the outcomes data that we look at for reporting. So, you know, past 30-day use, perception of harm, whether it's perceived as wrong by a peer or a parent. Those are ones we already asked for. I think what we should do, Lynn, is maybe send out an email to the roundtable and just ask who else would be interested, and I can attach your request.
That's fine.
Just get some feedback from others if they'd be interested in getting the same data, if they'd like to add on to that request, and we could submit one for all 5 counties.
That works for me. At least I hope we can get something for Pueblo.
Yeah, I think we can. What I've heard is that they're already queuing up data requests and that it might take a bit, but we should try and submit sooner than later if we can. We'll be busy into the summer fulfilling those. So.
Good, and thank you for helping with that.
Yeah, problem. So I'll do that. I'll just follow up in the email with that request that you started. So, well, any other updates that you guys wanted to throw out there? No? All right. Well, hopefully the Smart Course thing was useful. I think it'll be pretty neat to see what data you all can get access to. Oh.
Yeah, definitely. Thank you for organizing that, Peter.
Yeah. Well, actually, maybe one final request from you all. Any other types of presenters that you would be interested in hearing from? Resources you've come across that you'd like to share?
I mean, we've been trying to dig in a little bit more into some of the opioid stuff and prescription drug stuff because it hasn't been something that we've prioritized. But it seems like it resonates a bit more with some of the coalition members because it's been in the news and stuff like that. And it also seems like it might not be such a big issue for the consequences are not really seen in high school, but they're seen kind of immediately after that in the 25 to 35 range. We see a kind of a huge jump in mortality. And so the coalition has started thinking about prevention efforts at the high school level. So we've been digging into that a bit, but any help from you guys on that would be great.
I know we've talked about PDMP.
Yeah. God, yeah. Have we?
Would it be useful to have someone from CDPHE from their group talk to us about their set?
Yeah.
That would be good.
That would be good. I mean, I think that I mentioned this to you, but we asked them if we can get youth prescription data specifically for Aurora, and they quoted us that they wanted $15,000 or something for it, which was well beyond our budget. So if there's any way that they can do that without to talk about it without us actually having to pay for it, that would be great.
You went through Dora?
Yeah.
Wow.
And we had the Aurora Research Institute. I think they were the client that asked for it. They're the internal support for the mental health center.
So I made a data request from them for county level instances of doctor shopping.
Okay.
That didn't cost anything. I'm curious.
Didn't cost anything.
You went to the level.
Maybe they were gonna give us de-identified, unique level data. I don't know. I thought we were pretty clear with the data request, but maybe we screwed something up. So anyways, I would love to talk about the PDMP.
Okay, that sounds good. I actually just reached out to, I was at Public Health in the Rockies last year. I heard a presentation, and then that's the person I reached out for the data request. And just recently, she's going to present at an SEOW meeting. So I bet I can ask her if she would want to hop on one of our calls.
Cool.
So that sounds good. All right. Well, any other topics or types of presenters I'd like to hear more from? All right. Well, if any come to mind, find me. So, all right, guys. Well, have a good weekend. Thanks for being on the call. Appreciate it.
Thank you.
See you guys.
Okay. Take care.